Hello, everyone. My name is Katrina Sanders. I am the content creator, developer, and educator behind this multi-module airway and sleep disorder series that you're going to be experiencing. In a minute, you're going to be checking out Module 1. Module 1 has been created as kind of an introduction, giving us a little bit of an appetizer about the different types of patients that are likely walking in and out of our clinical doors every day, who are in fact suffering from an undiagnosed airway and subsequent sleep complication. This is an introductory course, or rather an introductory module, looking at the opportunities we have to change and transform our patients' lives. This first module is going to be the initial splash that we have into looking at the entire introduction, the whole host of ways that we can serve and support our patients. Throughout this module, you will receive not only the information delivered by me, but also the research around where we're capturing this information from. This content has been developed with my late mother, Linda Marie Sanders, in mind. My mother is one of thousands upon thousands of Americans whose lives are lost annually to undiagnosed, unaddressed, and needless complications. The reality is that we as oral health care practitioners certainly hold a critical opportunity to change the way our patients breathe. And so, Mom, this is for you. I hope you enjoy. Module 1 is an introduction and an overview of airway and sleep medicine management. Airway challenges and obstructed sleep disorders impact undiagnosed patients in a myriad of ways, with the vast majority of these disorders indicating systemic disease. This module delivers an introduction and an overview of current understandings of prevalence of disease and the unique role of the dental clinician in optimizing early and definitive identification of these life-altering complications. What we're talking about is the impact of untreated sleep disorders. Throughout the next 12 modules, we will unpack our critical role in being able to assess, diagnose, plan, and support our patients in seeking the level of care that they need to address a potentially untreated sleep disorder. Now, the impact of untreated sleep disorders really begins with patient safety. Patients who do not have their sleep disorders treated effectively can experience safety inside and outside of the home. This can be in complications with their personal or work relationships, or even the relationship they have with themselves. We see that in individuals who do not have sleep disorders addressed, that we begin to see a dramatic decline in both school and work performance. And this is attributed to a lack of clarity in thinking, complications with mental health, and subsequently, untreated sleep disorders can elevate the risk of weight gain and the development of chronic systemic diseases. One notation that I want to share before we even dive into our content for Module 1 is to critically look at how these modalities can even be seen in our patients who are walking in and out of our doors every day. Are we noticing that patients are sharing a change, a pivot, or a decline in some of their relationships? Have they noticed an unexplained decline in their work performance? Or are your parents of your pediatric patients noting that there has been a decline in school performance? Are patients notating things like a lack of clarity in their thinking? And I want to be very clear, sometimes this doesn't mean blaming the fog of feeling sick, the fog of aging, the fog of changes in hormonal modalities, or brain fog associated with those who have a history of experiencing the COVID-19 pandemic. Perhaps we've notated that our patients are beginning to experience some mental health issues. Maybe this is showing up like new medical conditions or mental health conditions being addressed on our patient's medical history. Maybe our patients are taking new medications. Maybe our patients are notating that they are seeing a therapist for mental health complications. Maybe our patients are noticing a weight gain, or maybe our patients are noticing that they are struggling to control their weight. Or, most often, the way that we will observe this in clinical practice is through the development of chronic diseases in our patients. These are patients who are going to notate changes like new diagnosis of a chronic disease like high blood pressure. Perhaps these could be hormonal changes, thyroid changes. Maybe this could be blood glucose changes. And so the development of these chronic diseases certainly can be a great indicator for us in the dental profession that our patient is experiencing some sort of a complication that may lean back on a potential untreated sleep disorder. My name is Katrina Sanders. I'm so excited to be here as your guide, your instructor, across your journey in identifying the ways in which we can help elevate, support, and serve our patients as healthcare providers. I am a practicing dental hygienist. And while perhaps the quest to identify the roles we play in airway and sleep is one for a dental hygienist, my presence here today is that of a concerned daughter. In 2018, my mom suddenly, tragically, and unexpectedly lost her life. My mom's cause of death was an airway obstructive disorder. My mom suffocated herself in her kitchen, collapsed, was discovered by my father, who was able to perform CPR on her just long enough to keep her organs alive. And we're very proud 5 people are alive today and can see because of mom's gifts of organ and tissue donation. But the reality is, my mom is no longer here with us. My mom had a complication that should have been identified by her dental hygienist. The very person who spends anywhere between 35, 40, 60, 90 minutes staring down her airway every 3 or 4 months that she would present for her periodontal maintenance appointment. Perhaps her airway obstructive disorder could have been evaluated by the ear, nose, and throat specialist my mom saw for a 4-minute appointment the morning she collapsed. I submit these modules not only as a dental hygiene educator, a practicing clinician, an international speaker, and a consultant, but most importantly, as the family member of someone who now celebrates Christmas, Thanksgiving, without their beloved family member. This module is about identifying what our true role is, not only in meeting our professional responsibility, but serving and supporting our patients. Our course objectives for Module 1 begin by looking at the prevalence of airway disorders, exploring some of the current challenges in diagnosing airway issues or complications, and finally, identifying the role of the dental practitioner in identifying airway complications. So for this, let's begin by taking a look at some of the risks, challenges, or complications that we oftentimes see in our patient population. Of note, about 90% of adults in the dawn of this new industrial age that we are in are currently breathing incorrectly. Now, this breathing complication, rather, is either causing or aggravating a complex list of various chronic diseases, things from asthma, anxiety, ADHD, emphysema, psoriasis, and many more. We understand that as our patients age, as we age, that our lung capacity declines. Lungs themselves will lose about 12% of our lung capacity from age 30 to age 50 and will continue to decline quickly as we get older. Unfortunately, women losing more lung capacity over men. If we make it to age 80, we are able to take in less than 30% of the air that we did when we were in our 20s, which is what requires us as human beings to breathe harder and faster. We look at breathing, and although it is an involuntary activity, we also understand that breathing, airway, the maintenance of our airway, is also voluntary. We can choose to take big, deep breaths. We can choose to breathe in through our mouth and out through our mouth. We can choose to breathe in and out through our nose. We can choose to take in breaths, hold them over extended periods of time, and exhale. We can choose to hold amounts of oxygen in our respiratory system or exhale everything. Or at least we thought it was partially voluntary. You see, our body's ability to force us to breathe, although involuntary, is guided by some of our complications. Our airway is a critical component to acquiring oxygen so that our bodies are able to deliver high levels of oxygen to our critical organ systems. And so, although we have perhaps taken breathing for granted, research has not, and it has continued to deeply unpack the importance of breathing in our longevity and our vitality. In the 1980s, researchers in a Framingham study, this was a 70-year longitudinal study focused on heart disease, specifically attempting to identify if it was lung size itself that was correlated with longevity. Remember, the size and the capacity of our lungs declines as we age. And this study of over 5,000 subjects over 2 decades of data gathered a very interesting indicator. This data discovered that the greatest indicator of lifespan, of longevity, of being able to live a long and healthy life wasn't genetics, wasn't diet, wasn't our daily exercise, which is what many thought. In fact, it was lung capacity. This research study identified that smaller and less efficient lungs gave way to sicker subjects that lost their lives sooner. The cause of the deterioration did not matter. Put simply, the smaller the lung capacity, the shorter the life. In 2000, the University of Buffalo conducted a similar study over 3 decades and found the same results. That our ability to breathe fully is, according to researchers, literally a measure of living capacity. Now, when we take a look at breathing modalities, it's important for us to understand what one of the major complications is. We're beginning to look at the fact that nasal breathing is a critical component to one aspect of health, wellness, and vitality for our population. Of note, about 40% of today's population suffers from some form of chronic nasal obstruction. Once that nasal cavity gets congested, this is where we see a decline in our airflow. And this is where we see the allowance of bacteria to readily flourish, which we understand elevates the risk of our patients experiencing specifically respiratory infections. Around half of today's population are habitual mouth breathers, with females and children suffering the most. And we are now beginning to identify that humans are the only mammal species on the planet who routinely present with misaligned jaws, overbites, and underbites. Where did this come from? Well, it began with essentially our raw food diet. Our ancestors 1.7 million years ago ate a raw food diet. And we saw from skull studies of our ancestors that we had a smaller brain cavity and a larger jaw cavity. However, as we began to evolve, we began to see that our cooked food allowed for our quickly growing brain to stretch out into our skull, which meant smaller vertically positioned noses were less efficient at filtering air, exposing us to more airborne pathogens and bacteria. The more we continued to cook our food into soft, calorie-rich foods, the larger our brains grew, the smaller our sinuses became, the smaller our mouths became, to accommodate space within our throats, to where we are now, with a large brain cavity and a small nasal cavity. Of note, our larynx slowly began to descend down into our throat, which accommodated for vocal communication, which also caused the tongue to slip further down the throat, pushing the jaw forward. When our mouths do not grow wide enough, our palate tends to rise up instead of out, which forms a V shape or a high arched palate. This upward growth impedes the development of our nasal cavity, which shrinks it, disrupting the delicate structures within the nose itself. The reduced nasal space leads to obstruction and inhibits airflow. When we take a look at the breathing process itself, it begins by pulling oxygen in through our nasal conchae. Air pulled in through our nasal conchae is then going to move through our air pipe. It moves through our pharynx down into our trachea. As air enters our bronchi, bronchioles, and subsequent alveoli or grape-like sacs, this is where the magic happens. These capillaries that surround the alveoli allow for diffusion. Within this alveolar sac, we see oxygen enters the capillary, as well as carbon dioxide leaving the capillary, entering our air sac, and being exhaled. This is the breathing process we have learned about from day one. And ultimately, we understand that while this is a critical component of it, so are other pieces, like our diaphragm, which expands and contracts, allowing for our chest cavity to move and allowing for our massive lungs to do the critical work they do best. When we take a look at breathing, it's important for us to remember that part of the critical layer in the size and function of our lungs really boils down to the ways in which we breathe. Breathing, we know, allows us the ability to have control over our immune response. It allows us to tap into our nervous system, and it permits us the ability to restore ourselves to health. We understand that a critical layer of the breathing process is being able to facilitate obligate nasal breathing. Obligate nasal breathing essentially means that instead of mouth breathing, we're pulling oxygen in through our nose. Ideal obligate nasal breathing allows us opportunities to regulate the temperature of the air being inhaled, so moving our air from cold to warm, hot to warm, or dry air to moist. It allows us to produce nitric oxide, which is a critical gas that aids in boosting immunity and ridding the body of bacteria within airborne particulates. It increases and encourages parasympathetic nervous systems and lowers our stress levels. It allows us to maintain our pH or our alkalinity of our blood. It allows us to increase oxygenation throughout the body. It aids in recovery. It increases our focus by providing a higher rate of oxygen to both the body and the brain. It improves our visceral organ function. It increases and improves venous return, as well as the activation of our diaphragm. It improves or increases the flow of our lymphatic system. It also, by the way, improves the quality of our sleep and tones our vagus nerve. Now, when we take a look at the illustrations as you see here, on the left are the facial characteristics of a good nasal breather. This nasal breather has a forward position of the jaws, high cheekbones, optimal airway size, and optimal width of the face. A strong jaw positioned well forward so that the chin is nearly as far forward as the tip of the nose. This absolutely is a clear indicator of a healthy individual who has an optimal airway. On the other side, however, we see an individual in which the jaw is set back or retruded. This allows for a smaller, more condensed or compacted airway. When the jaws are moved back, the eyes look tired. Poor definition in the cheekbones, and the face begins to sink downward. Chronic and habitual mouth breathing is oftentimes associated with postural changes, which result in decreased muscle strength, reduced chest expansion, and impaired breathing. These images here are critical aspects because we understand that as we start to see pivots or shifts, it not only is a cosmetic concern, but also that of a potential systemic concern. These features are readily identifiable in thousands and thousands of children and adults who are oftentimes encouraged to breathe through their mouth rather than through their nose. And these individuals will oftentimes suffer from poor health, low energy, and reduced concentration. These children do not sleep well throughout the night due to their obstructive airways. They grow up to become adults with a lack of sleep in which growth and academic performance has suffered, and we begin to see this manifest in some of our behavioral conditions. During mouth breathing, it is quite unlikely that the tongue is able to rest within the mouth. Try it. Open your mouth, place your tongue on your upper palate, and then breathe through your mouth. You'll find that it's quite challenging in order to effectively pull air in through the mouth. When we look for some of these clinical observations, we can oftentimes see them as things like lips that are never together, a mouth that will hang open, a flaccid lower lip that becomes larger over time, and this is also for an accommodation of trying or attempting to close the airway. The upper lip will draw up toward the nose, and the head may even project or protrude forward, following that class 2 occlusion. And so our concern ultimately becomes with this open mouth, lips apart resting posture, this orofacial disorder related to the lips. How does this manifest itself? Not only in the oral cavity, we see this in things like drying of the gum tissues affiliated with oral inflammatory components, but also the lack of protecting the teeth, which can elevate the risk of decay, and ultimately are going to impact the maintenance of the airway. So when we take a look at our head and neck examination findings, we as dental professionals are well positioned to identify, for example, inflammation within the throat or throat polyps, both of which contribute to snoring and sleep apnea. We know that nasal obstruction will trigger nighttime choking as mouth breathing increases. Every 3.3 seconds, a mouth breather will pull in a gust of unfiltered, unmoistened, unheated air through their mouth, drying out their tongue, irritating their throat, and complicating their lungs. This mouth breathing will also cause the body to lose 40% more water. But what's more, as our mouth breathers continue to escalate some of these complications within the lungs, we ultimately see this leading to sleep complications. So let's take a look at airway and sleep and how airway impacts the quality of our sleep. For this, we'll look at a broad definition of sleep. Sleep, by its very nature, is loosely defined as a condition of the body and the mind. The nervous system is relatively inactive. Eyes are closed. The postural muscles are relaxed, and consciousness is practically suspended. Sleep is a critical function that allows the body and the mind to recharge. It is intended to leave you refreshed and alert upon waking. Healthy sleep will also permit the body to remain healthy and to stave off diseases. Without enough sleep, the brain itself is incapable of functioning properly. Now, one critical piece that I do want to share about the definition of sleep, and we will get very comfortable and very cozy with this over the next 12 modules, is although we understand what the definition of sleep is, it's also critical for us to identify what quality sleep looks like, as well as the optimal duration of sleep based on the patient's age and or physiological needs. And so, to be very clear, sleep is intended to leave the person, the individual, the mammal, the animal, the organism, whatever it may be, refreshed and alert. The definition of sleep truly is a space of relative unconsciousness, practical unconsciousness, that allows for the body to recharge. During sleep, our cells are repairing themselves, muscles are being built. During our patterns of sleep, the immune system is thriving. The brain is relaxing. The brain is storing critical components. During sleep, it allows us to reestablish homeostasis. It allows us to repair, and it allows us to call upon our immune system. And yet, we do acknowledge that oftentimes we can see complications with sleep. One of these critical complications is snoring. Snoring and sleep apnea move in tandem. In fact, we oftentimes see that in individuals who are experiencing chronic insomnia, that there is oftentimes a breathing problem as well. We recognize that if an individual is experiencing snoring or sleep apnea, that there is an overt disturbance of oxygen within the brain. Most specifically, this disturbance of oxygen occurs within the prefrontal cortex of the brain, which subsequently reduces the development of brain cells. Therefore, we oftentimes see that when individuals experience a disturbance or an interruption of oxygen, oftentimes seen in sleeping and or subsequent apneic events, that these are individuals who then struggle with feeling refreshed in the morning. These are individuals who oftentimes struggle with cognition and memory. We recognize that this is a relatively prevalent condition. Of note, 90% of our children have an acquired deformity within their mouths and noses. 45% of our adults snore occasionally, with 25% of our adults snoring constantly. I'll pause for a short moment and say this in a different way. 90% of the pediatric patients who will sit in our dental hygiene chairs will sit in our chairs with an acquired deformity in their mouths and noses. 45% of our adult patients who are going to sit down in our chairs will occasionally snore. 25% of adults who will sit in our chairs are constant snorers. Of note, 25% of American adults over the age of 30 choke on themselves nightly because of sleep apnea. These complications of note are complications that oftentimes are not readily seen in their early stages. But we're dental hygienists, and we are experts in identifying chronic diseases that oftentimes are relatively difficult to assess, to diagnose, or oftentimes are nearly impossible for our patients to even identify. The proverbial, if it doesn't hurt, why do I need to fix it, could also be applied to sleep apnea cases. Oftentimes, our patients who are experiencing snoring complications have adjusted to a way of life, or in many cases, have no idea that they're snoring. And so it becomes critical for us to identify what is considered a variation of normal for our patients. Who are the ones who are experiencing these complications, and ultimately, how can we better serve, support, and protect our patients? This is where we begin to look at the suggested or recommended sleep times or durations for our patients. Taking a look at some of these sleep times, we recognize that as we age, the amount of sleep that is required based on the National Sleep Foundation declines. As a newborn, we should be getting anywhere between 14 to 17 hours of sleep per day. As we age into infancy, that declines to 12 to 15. Our school-aged children, 9 to 11 hours of sleep. As a teenager, we should be getting anywhere between 8 to 10 hours of sleep. As we move into young adult and adulthood, anywhere between 7 to 9 hours of sleep is considered an optimal duration, and older adults, anywhere between 7 to 8 hours of sleep. One critical piece I will share: these sleep times, or this duration, is a duration of optimal sleep. This does not mean the number of hours that an individual is laying in bed. For example, we could have an adult patient report to us that they are in bed or they sleep for 8 to 9 hours a night. So one could assume that this individual is getting the optimal recommended amount of sleep. However, once you begin to ask the patient about the quality of sleep, how long does it take the patient to fall asleep? How long does it take them to move into deep sleep? How long do they wake up in the middle of the night? How many times do they wake up in the middle of the night? Are they experiencing sleep disorders like sleepwalking, sleep talking, restless leg syndrome? Are they experiencing apnea issues or snoring that can oftentimes wake a patient up? All of these interrupt the optimal sleep time duration and can subsequently make it that much more challenging for our patients' bodies to repair themselves. This is where we start to look at the concept of what we call sleep fragmentation. Sleep fragmentation is loosely defined or characterized by repetitive short interruptions of sleep, most commonly caused by individuals who are experiencing sleep apnea. This could also be caused, by the way, by periodic limb movement as well. We'll take a look in a minute at appropriate sleep cycles, but the average full sleep cycle from stage 1 of our non-rapid eye movement to REM sleep will range anywhere between 90 to 110 minutes in its average cycle. Sometimes when we take a look at sleep patterns, longer sleep times might be notated due in part to an overtired patient, a depressive patient, or simply somebody who is laying in bed but not simply acquiring optimal sleep. The ramifications of insufficient sleep continue to become an interesting quest for exploration in the research space. Of note, insufficient sleep has an estimated economic impact of over $411 billion annually. We talked about safety early on, and it is important to notate that insufficient sleep can impact safety in our patients. For example, over 6,000 fatal car crashes occur annually due to drowsy driving. Nurses who work a 12.5-hour shift report committing 3 times as many medical errors as that of their colleagues who work an 8.5-hour shift. 40% of individuals with insomnia are believed to also be impacted by a mental health disorder. And approximately 75% of adults with depression suffer from insomnia. Is it possible then that by correcting an individual's sleep, or by correcting our patient population's sleep disorders, that we could be assessing or addressing the over $400 billion economic impact? Perhaps we could make our roads safer. Perhaps we could reduce the risk, the complications, the issues affiliated with medical errors. Perhaps we could address mental health disorders by more than simply prescribing a medication to our patients. Let's take a look at the sleep cycle to better identify where sleep complications can oftentimes arise. Of note, when we begin the sleep cycle, when we begin to put our heads down on the pillow, we move into stage 1, non-rapid eye movement. This is a light sleeping, the first 5 to 10 minutes of the cycle. In the dozing off stage, our brain is beginning to slow down. If we wake up in this stage, it might feel like we haven't fallen asleep at all. As we continue into non-rapid eye movement stage 2, this is where we see light sleeping, which will then allow our patient to enter into a deeper sleep. This is where we see muscles beginning to relax, body temperature beginning to drop, heart rate, breathing slowing, our eye movement begins to stop, and our brain waves begin to slow. We begin to see little bursts from our brain that are believed to assist with memory storage, as well as shutting down the senses so as not to interrupt our sleep. As we remain in stage 2, we then enter into non-rapid eye movement stage 3, deep sleep. That could last any more than 20 to 40 minutes, and of course gets increasingly shorter as our sleep cycles will progress. In fact, we find that as people age, they spend less time in this stage 3 and more time in stage 2. Our eyes and muscles are fully at rest, and this is when our body is in a state of repair. We're regrowing tissue. We're strengthening our immune system. We're building bone and muscle. At this point, it is quite difficult to awake. If woken, participants may experience some disorientation or brain fog, which leads us into our final stage, rapid eye movement or REM sleep, also known as paradoxical sleep, which, by the way, has many physiological similarities to that of wakefulness, even though the body is paralyzed. We see electrical bursts from the brainstem, which allows for fluctuations in our breathing patterns and a stabilization or suspension of homeostasis. Interestingly enough, brain energy equals or exceeds oxygen and glucose metabolism when compared with being awake. Researchers are still trying to figure out how or why this happens. But in REM sleep, our brain is requiring the same or more oxygen and glucose than we do when we're awake. And most notably, REM sleep is linked to our dreams. At any point, an interruption in our sleep patterns can create an overt challenge for us, not just from a lifestyle component, but, as we'll see in a minute, from a systemic risk factor component. We can see lifestyle implications associated with our sleep patterns. We could see if we have an impacted sleep pattern, we could observe bruxism habits. Our sleep hygiene could decline. And we'll take a look at sleep hygiene in future modules. We could see periodic leg movements, parasomnias. We could begin to see sleepwalking experience of nightmares or sleep talking, uncontrolled urination. We also see, by the way, that things like our work schedules can become impacted or can impact sleep patterns. We see circadian body rhythms becoming out of sequence. Medications can also impact our sleep patterns. We know that caffeine intake, tobacco, or alcohol use can impact or affect sleep patterns, as well as stress, or in many cases, travel outside of a typical time zone. But what's more, we also see systemic risk factors associated with apnea. These are things like an autonomic dysfunction. Our autonomic nervous system begins to experience a dysfunction, which leads to a rise in blood pressure. Or we could see an increase in hormones like aldosterone made by our adrenals. This hormone is intended to control sodium and potassium, and yet if we get too much buildup, we could see an elevation in hypertension. I'll take a pause there. Oftentimes, when we see patients who present in our chairs with high blood pressure, they're on medications. And to be very clear, they're on medications to control their blood pressure. Oftentimes, we're not treating the patient based on the root cause. When our patient is experiencing high blood pressure due to a sleep apnea issue, that high blood pressure is the body screaming for help. And us giving the patient medications is silencing the screaming, but it certainly does not mean that our body does not need help. And so when we take a look at some of these risk factors, consider that some of the patients sitting in your chair may begin to demonstrate some of these risk factors early on. A raise in blood pressure or a resistance in insulin could be clear indicators that the patient is experiencing a sleep apnea event. We can also see dysfunction of our endothelial lining, and we'll talk a little bit more about that in a quick minute. We can see inflammation within our vasculature and an increase in our reactive oxidative species. Most importantly, we begin to see vascular remodeling, growth of our arterial smooth muscle, which leads into increased adhesion, coagulation, and endothelial growth within our vascular system. Put simply, the fact that our patient is not acquiring optimal rest, not pulling in optimal nitric oxide, conditions, primes, and allows for the smooth muscle lining of our blood vessel walls, our endothelial walls, to allow for increased adhesion and coagulation, allowing for more blood clots, clogs, or cuts within our smooth lining. This is where we start to see an elevated risk for cardiovascular disease, things like AFib, obesity, or diabetes. In fact, patients with coronary artery disease who were not only treated for their coronary artery disease, but more specifically were treated for their obstructive sleep apnea experience, demonstrated a 76% decreased risk of a cardiovascular event when compared with those who remain untreated. So, let's take a look at what it is that we understand about dental sleep medicine, why dentistry, and why sleep patients. Well, first and foremost, we are at the front line of becoming true preventive specialists. We sit, we communicate, we coordinate with patients, where we have an over-the-balcony look at a lot of our patients' sleep-wake cycles. We spend an incredible amount of time talking to our patients about potential physiological effects, and we notate these things. Some of the abnormalities that we can see will begin first and foremost with our team members in our practices who may experience maybe shift disruptions. This could be in our patients who are nocturnal workers. This could be in our medical colleagues who are night shift workers. Night shift workers in particular suffer from inadequate and poor sleep quality because they're required to work when their body clock is telling them that they actually should be asleep. This shift work disorder is associated with various forms of mental health as well. The psychological effects of inadequate or poor quality sleep, compounded by the disruptive influence of this shift work on family and social life, are commonplace for these shift workers. And these physical health issues certainly can easily overshadow and distract from the true origins of the primary problem. Of note, this impacts over 20% of our workforce. And so consider that a large portion of your patient population, especially those who struggle to schedule their hygiene appointments routinely because of their night shifts, are terrific candidates for an evaluation of sleep. We also know that there are other things that can impact sleep. The effects of jet lag are usually short-lived, but travelers who do frequently cross over time zones on flights can experience chronic sleep disturbances, performance, and physical well-being complications. Difficulty in getting to sleep until very late, and problems with getting up in the morning, as well as sleepiness throughout the day, sleeping in late on the weekends. These characterize what's called a delayed sleep phase syndrome. They are easily misinterpreted as being awkward, lazy, or irresponsible behavior. However, this sleep disorder does occur more often in adolescence and is a result of course, a combination of the puberty biological clock changes, as well as alterations in lifestyles involved with staying up late for study or social reasons, but can also be exacerbated by alcohol or drug intake. We can also see advanced sleep phase syndromes affiliated with changes in body clocks in old age. There's a tendency to fall asleep sooner in the evening. This is, of course, the opposite of the effect that we see during body clock changes in puberty when we want to stay up later. The advanced sleep phase syndrome is likely the result of being up early in the morning when sleep requirements have already been met. Remember, as we get older, our sleep requirements decline. This should not be mistaken for the early morning waking associated with depression. We also understand that sleepwalking can be a common complication. Sleepwalking may involve calm walking in a semi-purposeful manner. Sometimes it can be agitated sleepwalking or even sleep terrors in which the individual is experiencing fear, distress, even crying, screaming out, or trying to escape from danger. Other sleepwalkers can actually develop an eating disorder with an excessive weight gain due to the amount of food they consume while they're still asleep. Yet others can behave in aggressive or destructive components in which they may injure themselves or others around them. Young children can have what's called confusional arousals, which may be thought by their parents to indicate that the individual is ill in some way because of the degree of behavioral disturbance involved with sleep terrors. It's important as we begin looking at some of these sleep disturbances that our relationship we have with our patients allows us to become well positioned to identify a lot of these potential complications for our patients. We can also see, because of our nature, challenges in even diagnosing some of these sleep disorders. Of note, sleep disorders are among the most common complaints seen by general practitioners. They also complicate many conditions in which there's a referral to a specialist. However, just because sleep disorders are a common complaint doesn't mean that we in the medical and subsequent dental community are well positioned to diagnose these sleep disorders. Of note, One of the major challenges that we see in diagnosing sleep disorders is that the general public is not particularly well informed of what a sleep disorder actually is. In the age, particularly in the American culture, of this sensationalization we seem to have with being overworked, overtired, and guzzling cups of coffee, cans of pop, anything that has caffeine so as to keep us awake throughout the day, has certainly sensationalized and perhaps declined our perception of the importance of identifying potential sleep disorders. Consider that when a patient reports that they drink a certain amount of pop or tea or coffee throughout the day, that maybe our concern is more than simply their caries risk. Perhaps these are individuals in which we should be asking them about potential sleep disorders. Are you getting enough sleep at night? Etc. There's also a lack of understanding about what a sleep disorder actually is. Excessive sleepiness, whatever its cause out of many possibilities, is oftentimes misjudged. We think that it's lazy. We think that these are people who just are daydreamers or lack motivation or are depressed or have intellectual inadequacy. And yet, because of our lack of understanding and perception of sleepiness versus mental health disorders, it certainly complicates the way that the medical community participates in sleep disorders. Additionally, medical professionals are not well informed about sleep disorders. In fact, a 1998 survey of the UK medical school system revealed that out of a typical 5-year programmatic content for medical students, the median amount of time spent on formal teaching about sleep and its disorders was 5 minutes. And so it stands to reason that our medical schooling system has not positioned our medical colleagues well to really understand sleep or its disorders. Finally, we don't ask. We typically do not inquire about sleep symptoms. Certainly the medical community does not, nor do most dental professionals. And oftentimes it is in the identification of sleep symptoms that we are able to prescribe treatment. When we see a patient who has a sleep symptom, the first modality that most medical colleagues will go to is the reliance on medication. Medicating our patients to relax them, to put them into a deep sleep, versus potentially identifying causation for these sleep disorders. We've understood well that there are complications associated with airway and subsequent sleep disorders. In fact, current studies indicate that over 60% of our adult patient population constantly fall short of the appropriate amount of sleep. Is it that we're too busy to sleep? Or is it that we are not acquiring quality sleep once we turn down for the evening? People who struggle with obstructive sleep apnea present with elevated risks for systemic diseases. Most specifically, individuals who have a sleep apnea disorder have a 30% elevated risk of experiencing a cardiovascular event. Interestingly enough, approximately 38,000 Americans die each year from cardiovascular disease with sleep apnea as a complicated factor. About 80 to 90% of individuals with sleep apnea are currently undiagnosed. Which finally leads us to perhaps the most important question of this entire module system. And that is, why dentistry? Well, because about 80 to 90% of these individuals who have sleep apnea are currently undiagnosed. Most individuals who present to a primary care physician are presenting, and this particular primary care physician, on average, current statistics indicate, have 9 minutes and 36 seconds to perform a comprehensive exam on this patient. What about our patients who present to a specialist or an emergency room situation? Our medical colleagues are not well positioned to screen for slow, progressive chronic diseases in the same way that we are. In fact, it should be notated that about 27 million people will visit a dentist annually, but not a physician. Data indicates that more than an estimated $100 million could be saved each year if dental offices participated in critical medical screenings like identifying diabetes, high blood pressure, and high cholesterol. I implore you to consider that another addition to this list would be sleep and airway complications. That if we in the dental community can be an active participating role in screening for the 80 to 90% of individuals who are currently undiagnosed but yet experience a sleep disorder, that we could be a critical part, a critical component of supporting our patients in identifying not only systemic diseases, but also addressing psychological and mental health conditions, showing up better in their relationships, performing in school or at work, and ultimately feeling more refreshed and revitalized to live their lives. The future modules will allow us to critically look at the various steps within the dental hygiene process of care in which we are able to support our patients. I will leave a short, basic screening question. I implore you to begin this module series by evaluating yourself. Do you have any difficulty getting off to sleep or staying asleep? Are you very sleepy during the day? Do you experience any disturbed episodes throughout the night? I'm going to leave these basic questions with you, as these are going to be the first step in us participating in sleep and potential airway complications. Future modules will allow us to dive much deeper into medical history and patient report screenings, but this should help you to get an initial start. Well, I hope that you've enjoyed the content that you've experienced in the introduction and overview module. Throughout this series, we also have an incredible and exciting lineup of content. We will be dripping content following the dental and dental hygiene process of care. So the next module that will be dripped in this series will move on to the assessment phase, looking at medical history and the importance of identifying some of those comorbid complications that are associated with either undiagnosed or poorly addressed airway complications. We move on to continuing the assessment phase, looking at underlying medical conditions or even vital signs that could result as a component of a poor sleep or an occluded airway. We're also going to be diving into tethered oral tissues, looking at some of the head and neck examination findings that will help us to identify orophacial complications. We'll also look at oropharyngeal observations. So beyond tethered oral tissues, looking at malocclusion or oropharynx complications. Then we're going to move on to the diagnosis phase, identifying potential airway complications and looking at particularly what happens if nasal breathing is not achieved. We're going to dive into the planning phase, looking at risk assessment and lifestyle habits, in which dental healthcare practitioners are very well positioned to identify these potential risks associated with airway obstructive disorders. We will continue by helping develop a therapeutic plan. It is in fact critical that when a patient is diagnosed with an airway obstructive disorder, that we aid the patients in helping them understand their treatment plan options. And so we will move into that therapeutic plan phase while also looking at patient communication strategies. We will round out our module series by looking at the implementation and subsequent evaluation phases. In the implementation phase, we're going to look at therapeutic modalities and some of the critical aspects about how we can deliver optimal care to address airway challenges and subsequent sleep disorders. And the evaluation phase, looking at maintenance and evaluation. How do we continue to maintain these chronic airway or sleep disordered patients throughout the rest of their time as patients? How do we evolve in their care plans? Followed by our final module, looking at the business of airway and sleep management. I hope you know that this, in my opinion, is the first of many opportunities that we as oral healthcare practitioners have when it comes to participating in this critical conversation. Please be prepared that additional modules can and should be created as the research, data, and our pivotal role inside of managing these diseases continues to evolve. And so I am pleased to continue launching these series. Please select the button below in order to continue the series. Thank you so much, and thank you for your dedication and the responsibility you feel to helping serve patients who very much need the level of care that this module series will prepare you to provide. It is so critically needed. Thank you.